As certified registered nurse anesthetists, we're trained to anticipate the unexpected, adapt to the unknown, and ensure safe passage through the perioperative journey. But what happens when the unknown walks in already inhaled? This video will help you navigate the evolving landscape of perioperative care for cannabis-using patients, with the goal of making you feel more prepared and confident. Historically, research on the effects of cannabis has been restricted in large due to its classification as a Schedule I drug under federal law, designating the drug as having a high potential for abuse and no accepted medical use. However, in recent years, state laws have evolved to permit the use of cannabis, making it legal for medical use in 39 states and for recreational use in 24 states, including Ohio in December of 2023. With the legalization of recreational cannabis use in Ohio and across the country, more patients are openly disclosing their cannabis habits. Yet many of us providing anesthesia are left asking, what exactly does that mean for anesthetic management? Are we confident in how cannabis interacts with our anesthetic plans? This brief, evidence-based video aims to answer those questions. We'll explore the physiologic effects of cannabis, its pharmacologic interactions with anesthetic agents, and current best practice recommendations to guide safe perioperative care. Cannabis, also known as marijuana, comes from the cannabis sativa plant and contains over 100 active compounds known as cannabinoids. The two most well-known are delta-9 tetrahydrocannabinol, or THC, and cannabidiol, or CBD. THC is the primary psychoactive compound responsible for the high associated with cannabis use, while CBD is non-intoxicating and known for its potential anti-inflammatory and anxiolytic effects. These compounds interact with a naturally occurring system in the body called the endocannabinoid system, which plays a critical role in regulating mood, memory, pain perception, appetite, and immune function. When someone uses cannabis, whether by smoking, vaporizing, ingesting, or using topical preparations, THC and CBD bind to cannabinoid receptors called CB1 and CB2. CB1 receptors are found primarily in the central and peripheral nervous systems, while CB2 receptors are located mainly in immune cells. The psychoactive effects of THC are largely due to CB1 receptor activation, whereas CB2 receptor activity influences inflammation and immune modulation. Cannabis impacts nearly every major organ system and has both acute and chronic effects that influence anesthesia management. Cardiovascular effects include tachycardia, vasodilation, and fluctuations in blood pressure. Acute cannabis use may cause transient increases in heart rate and cardiac output, while chronic use has been linked to myocardial dysfunction and arrhythmias. According to a study conducted in 2020, chronic users may have structural cardiac changes that can influence hemodynamic stability during anesthesia. Respiratory effects are also significant. Inhaled cannabis smoke irritates the airway and can lead to bronchitis, emphysema, and airway hyperreactivity. This means patients who chronically inhale cannabis may have an increased risk of laryngospasm, bronchospasm, and desaturation during induction or emergence. Neurologically, THC alters neurotransmitter release, affecting cognition, coordination, and memory. Chronic use can lead to tolerance, dependence, and in some cases, withdrawal symptoms such as irritability or insomnia. The pharmacologic interactions between cannabis and anesthesia are largely due to how cannabinoids are metabolized in the liver. Both THC and CBD are processed through the cytochrome P450 enzyme system, specifically CYP2C9 and CYP3A4. This is important because many anesthesia medications, such as propofol, Versed, fentanyl, and certain volatile agents, are also metabolized through this pathway. Cannabis can therefore either inhibit or induce these enzymes, leading to unpredictable effects on drug metabolism. For example, chronic cannabis users often require higher doses of propofol for induction, according to a 2021 case control study examining cannabis use and propofol requirements during endoscopy. However, THC's inhibition of CYP450 enzymes can also prolong sedation and delay emergence from anesthesia. Cannabis may also alter opioid receptor sensitivity, resulting in higher postoperative opioid requirements and reduced analgesic effectiveness. And CBD, while non-psychoactive, can still potentiate sedative effects when combined with benzodiazepines, opioids, or other central nervous system depressants. According to the American Society of Regional Anesthesia and Pain Medicine guidelines, as shown on the left, and supported by the American Society of Anesthesiologists, all patients should be screened for medically relevant substances, including cannabinoids, regardless of whether their use is medicinal, recreational, or illicit. During the preoperative evaluation, CRNAs should ask every patient about the type of cannabis product used, dose and frequency, route of administration, and time of last use. These details help us anticipate potential drug interactions, hemodynamic instability, airway reactivity, and altered anesthetic requirements. The ASRA guidelines emphasize that while routine laboratory testing for cannabis, such as urine or blood screening, is not recommended unless clinically indicated, a focused history and assessment for acute intoxication is vital. Signs such as tachycardia, anxiety, or impaired coordination may suggest recent use and increase perioperative risk. If acute intoxication is suspected, it's advisable to delay elective surgery, as cannabis-related physiologic changes can complicate airway management, cardiovascular stability, and anesthetic emergence. Patients who use cannabis should be encouraged to abstain for at least 72 hours before elective procedures when possible. At the Cleveland Clinic, current perioperative guidelines recommend that all herbal medications and supplements, including marijuana, non-FDA-approved THC-containing products, and CBD-containing products, be discontinued for 14 days prior to surgery. Intraoperatively, CRNAs should anticipate higher anesthetic and analgesic requirements in chronic cannabis users. Studies have shown that cannabis users may require higher concentrations of volatile agents, specifically sevoflurane and intravenous sedatives, to achieve adequate anesthesia depth. Chronic stimulation of CB1 receptors can desensitize neural pathways, leading to tolerance and increased anesthetic needs. Hemodynamic monitoring is especially important. Cannabis-induced vasodilation may cause hypotension, while sympathetic stimulation may trigger tachycardia. Direct-acting vasopressors, such as phenylephrine, may be more effective than indirect agents in treating hypotension in this patient population. Airway reactivity should also be considered. For patients who smoke cannabis, pre-treatment with bronchodilators may reduce the risk of bronchospasm during induction or emergence. Lastly, be cautious when administering opioids or benzodiazepines, as the combined sedative effects with THC or CBD can lead to delayed emergence or respiratory depression. Postoperatively, cannabis users often report higher pain scores and require increased opioid dosing for pain control. Chronic cannabis use can alter opioid receptor activity, reducing analgesic effectiveness. To optimize recovery, employ multimodal pain management strategies. This may include regional anesthesia, acetaminophen, NSAIDs, or non-opioid adjuncts. Because THC and CBD can prolong sedation, monitor these patients closely for delayed emergence or respiratory depression. Additionally, for patients with cannabis use disorder, withdrawal symptoms may occur within 24 to 48 hours after cessation. Symptoms can include irritability, insomnia, or anxiety, so postoperative assessment should include screening for these signs. Based on current evidence and professional guidelines, here are key recommendations for CRNAs managing patients who use cannabis. Conduct thorough screening for cannabis use during the preoperative evaluation, including frequency, route, and timing of last use. Advise preoperative abstinence for at least 72 hours before elective surgery when possible. Anticipate increased anesthetic and analgesic requirements in chronic users and adjust dosing accordingly. Monitor for cardiovascular instability intraoperatively and treat hypotension with direct-acting agents. Implement multimodal analgesia postoperatively to optimize pain control while minimizing opioid use. It's essential to monitor postoperative patients who use cannabis for withdrawal, which can begin within 1-2 days after the last use and may persist for up to 2 weeks. I invite you to complete a brief evaluation form using the QR code provided on the next slide. Your feedback will be anonymous and will help measure the effectiveness of this educational module. Thank you for your time, your dedication to patient care, and your commitment to ongoing learning in our profession.